المحاضرة اللي السلام عليكم. بسم الله الرحمن الرحيم. هي تتم المحاضرة اللي أعطاها دكتور زياد. It's going to be talking about evaluating the acute stroke patients. كيف يتم evaluating the acute stroke patients, mainly to use the scales, mainly ال NIH stroke scale, ال NIH stroke scale, which is standard scale to measure the severity of a stroke. يعني شدة الإصابة بالجلطة الدماغية. Good. Just 1 second. Nothing to disclose. So بالتحديد الاوتلاين اول شيء حنحدد what is NIH stroke scale or National Institute of Health stroke scale. Why it is important? It is a valid tool. And then we'll go over the items, which is 15 items of NIH stroke scale. I'm going to walk you through كيف يتم how you can do NIH stroke scale, which is not that hard. Then I will provide you the link like where you can get yourself educated about it. So هلا مثل ما بنعرف ال TBA thrombolysis can be given up to 4.5 hours, and in the future, close future is going to be the TNK. And however, number need to treat range between 2 for 1 to improve if you treat within the golden 1 hours, and 14 if you need to treat up to 4.5 hours. But what's more important, انك تعرف انه when you want to give the TBA, there is things favoring you treat the TBA. The favoring for treating the TBA, things not favoring of the treating the TBA is the severity of stroke. Always you look at the severity of stroke. يعني المريض اللي معه mild stroke بس hand weakness or facial weakness or just vertigo, you do not give him TBA. Whereas المريض اللي معه moderate to severe stroke, you give him TBA. And the way to distinguish mild from severe stroke بناء على السكيل اللي بنقول له NIH stroke scale. NIH stroke scale. أضف لهذا الأمر, lately with the interventional trials of doing mechanical thrombectomy up to 24 hours. Now the window started 6 hours, 8 hours, then lately up to 24 hours. You have to have a significant deficit, as I will show you. For example, ESCAPE trial, interventional trials, if you treat patients with the TBA only, 3 من 10, they do very well. 3 out of 10, 30%. If you treat them with taking the clot out, mechanical thrombectomy, 5 out of 10, 50% do well. And then that window expanded from 12 hours up 6 hours, 12 hours, then up to 24 hours. ل 24 ساعة, 24 hours, based on 2 important trials, down trials and diffuse trial. However, if you look at the criteria of treating patients with mechanical thrombectomy up to 24 hours, you very much rely on NIH stroke scale. As you see, you need to have a significant deficit with NIH stroke scale more than 10 to get that. Now, and that's for to include in the trial. But in general, what I will say, you need an NIH stroke scale of 6 or more to consider mechanical thrombectomy. And case by case, because this is a very interventional procedures, you need to deserve it for the patients who has a significant deficit. بناء عليه, this is the AHA guideline in 2018 to treat with mechanical thrombectomy. Patients has to have a large vessel occlusions, M1 or terminal ICA, or vertebral basal or artery occlusions, has to be more than 18. You can do it in young. We are doing it in young now. And you have to have an NIH stroke scale more than 6. So 6 or more. Here's the importance of quantitating the severity of the stroke by measuring the NIH stroke scale. الأمر الآخر, you need to have an aspect. It means the aspect on CT scan. This requires separate lectures, inshallah, about reading the CT scan in acute stroke, aspect 6 or more. And you need to initiate the treatment within 6 hours, but now it's up to 24 hours. So at first we used to use the rule of 6, NIH more than 6, aspect more than 6, treat within 6 hours, but now 6, 24 hours. Treat within 24 hours. طبعا, up to 6 hours, you can treat without advanced imaging. Up to 24 hours, you need the advanced imaging. You need to do diffusion, perfusion, MR, or CT perfusion to define tissues at risk. So I like this graph because this explains everything. everyone should be treated in stroke unit. We should build up the stroke unit for patients who require rehabilitations to be treated in the stroke unit. Everyone should get aspirin. You like in the range 15-20% will receive IVTBA, and 10% or 1 out of 10 should receive intervention mechanical thrombectomy. And definitely the number need to treat drop. You know, if you treat with aspirin, you need to treat 100 patients for 1 to prevent 1 stroke, whereas if you treat with thrombectomy, you treat 3 for 1 to recover. So you see the number need to treat very much drop when you move from all strokes, everyone receive aspirin, to who receive thrombectomy. However, the denominators drop again, also. So less number receive thrombectomy, patients receive thrombectomy. But this is the diameter of treatment. So I will skip that. This is about the telemedicine. So what is NI stroke scale? It's an objective measurement of stroke severity in acute ischemic stroke. It's very critical, very important scale to use to assess patients in acute ischemic stroke for IVTBA, because the severe the stroke, the more severe the stroke, the more you're going to give with the IVTBA. It's very important to assess the patients in mechanical thrombectomy for taking the clot out. You need an NI stroke scale 6 or more to consider the patients for mechanical thrombectomy. If NIH 1 or 2, you do not consider these patients for mechanical thrombectomy or IVTBA because the deficit is mild. Again, one subject I skipped due to the time is the telestroke. When you use telemedicine and assess patient through telemedicine, telestroke, we quite often use the NI stroke scale. NI stroke scale is a good measurement for stroke severity and for assessment and plan of actions based for IVTBA or mechanical thrombectomy. Let's go over the elements of NI stroke scale. As you see, there is 11 item, but some items has a right and left side. For that reason, there is 15 points, but there is 11 items in it. And if you want to be certified, which is simple, you can go several cases, get trained, and all these things. This is the link for training on NI stroke scale. So you can go online, get trained on NI stroke scale, and feel comfortable to do it. So the NI stroke scale is a standardized and repeatable assessment of stroke patients. Has a high inter and intra-observer agreement, used in clinical judgment, in treatment, and in clinical research. And the higher the score from 0 up to 30, the higher the score, the more severe the deficit. 0 score, it means patient's back normal. Just trying to move the, yeah. However, you need to understand that NI stroke scale do not replace your neurological exam. Neurological exam will be more detailed, more sophisticated one to assess your stroke patients. In addition, the NI stroke scale is less representative for the right hemisphere than the left hemisphere. And some patients with posterior circulation stroke will present vertigo, ataxic. If you measure their NI stroke scale, can be 0 because they don't have a limb ataxia, they have a gait ataxia. And in this way, the NI stroke scale is not that accurate in defining posterior circulation stroke. Moving this. Yeah. So what does it do? You do 15 parts. As I said, there is 11 items, but the 15 parts, because some of the items you measure strength in the right, left, 15 items. You test the language, the vision, the motor, the sensations, and the coordinations. If you have an NI stroke scale of 0, it means patient is back normal, has no deficit. And there is a lot of pitfalls in NI stroke scale. You can go through this website and look at the pitfalls and all these things for learning. Let's start with the first item in NI stroke scale. Item number 1 has a three subgroups. Number one, you assess the level of consciousness. يعني مستوى وعي المريض, level of consciousness. If patient is alert, open his eyes, fine, you don't need to stimulate him to open his eyes and respond. So it means he's alert 0. If patient is not alert but arousable, if you speak to him or you do stimulants, pain stimulants, then 1. If patient is comatose, not alert, you require to stimulate him frequently by either pain stimuli, then it's the score 2. It means patient is obtunded. If patient is worse than that, severely comatose, do not respond at all to pain stimuli or to voice, or both. And to pain stimuli, respond by flexing or extensions, the cerebral posturing or the cortical posturings, with the reflex motor or autonomic flexures or this or withdrawal, then you score him 3, or if he's a flaccid. So 0 alert, 1 drowsy, easily arousable, 2 obtunded, require frequent stimulations to be aroused, and 3 he's comatose, do not respond to regular stimuli, to pain or voice stimuli, except by the corticate or the cerebral posturings or withdrawal. So that's the first one, items of level of consciousness. The second item of level of consciousness, if patient is awake, alert, you ask them الشهر والعمر, what months, you ask the patients about the months, what months we are in, and how old are you. If he cannot answer neither questions, you give them 0. If they can answer 1, you give them 1. If they answer both, you give them 2. So I'm sorry, if he answer both questions, you give them 0. If he answer 1 correctly, you give them 1. If he answer both, or he cannot answer both, or give wrong answers for the months we are in, or how old is he, then you give him 2. So it will be 0, 1, or 2. So this is the second part of level of consciousness. So of course, patients, sometimes you run patients with aphasic, they cannot speak, they cannot understand amount aphasia. These patients will be scored automatically too, because they cannot answer. Either they cannot comprehend or they cannot speak, expressive or receptive aphasia. البارت الأخيرة, third part of the level of consciousness, is the command. Ask the patients to open and close their eyes. Could you please open your eyes and close your eyes? Then ask the patients to make a fist and then release their hands. Fist, then release their hands. So if patient can perform 2 tasks normally, then you give them 0. If he can open his eyes, close it, but he cannot make a fist and let his hands go, then you give them 1. If he cannot perform the 2 tasks, then you give them 2. Again, if you have a patient who is aphasic, then you very much give them 2. So 0, 1, or 2. So the level of consciousness, 3 items: the arousal, the questionnaire, and the command. Arousal, questionnaire, command. Now again, you do not need to remember these items as long as you have it in a pamphlet or on your phone, NI stroke scale, and you can very much score it. But what's more important is to know how to perform the test. بعد ما خلصنا level of consciousness, we'll move to the item 2, which is gaze, best gaze preference. So if patient is moving his eyes right and left and staring to the front and moving eyes right, there's no gaze to one side or limitation in gaze to one side, then this is normal. So you ask the patients look left, right. You can assess the patients, and he moves his eyes in all directions. Now, patients who is not comprehending, you do the doll's eyes. You move the head and look at the eyes movement. So the eye that can track you or can move left and right with no limitations, I will give them 0. If there is a gaze preference, partial gaze preference to one side, then I will give them 1. It can be partial or forced deviations. The forced deviations quite often associated with head, with neck, with turning neck to one side. So if patient, like for example, I'm here, a patient is just gazing to the left and they cannot gaze to the right, I will give them 1. If patient is gazing to the left and head turn to the left like this is severe eye deviations, then I will give them 2. So 0 normal, they move their eyes all directions. 1 gaze preference to one side, and 2 gaze deviation to one side. The way to examine it, patient awake alert, you ask them to look left and right. Patient is not comprehending very much, you or unresponsive very much, you move their head right, left, doing those eyes and look at the eye movement. So what you see there is very much the doll's eyes, like you move his head to the, like head in mid positions, am I right? Then you move their eye, you move their head to the right side, then their eyes move to the left side. You move their head to the right side, so to the left side, then eyes move to the right side. So oculocephalic, based on what you see, is intact. So then you give them 0. Whereas if they have a paralysis in moving their eye to one side, you give them 1. And if they have a forced deviation of the eye to one side, then you give them 2. So in patients who is comatose, this is what you expect with those eyes. Whereas in patients who is awake alert, their eyes will be fixed very much on objects because this is more of cortical reflex. So the frontal eye field is an interesting, that's what you are testing there with the gaze preference. You're testing the frontal eye field. The frontal cortex, the corticofrontal tract, frontal cortical tracts, travel with the corticospinal tracts to the crossing the midbrain, the contralateral horizontal eye movement. So عندك so عندك I'm sorry, just a second. So the eye move to the right side, the left frontal eye move the eye to the right side, the right frontal eye move the eye to the left side. So the eye track right and left, right and left, right and left. If you have a stroke on one side, then the eye cannot move to the contralateral side. The eye will be deviated towards the stroke. So in cortical stroke, patients will be, his or her eye will be deviated towards the stroke. That's the opposite in brainstem stroke. In the brainstem stroke, the eye cannot move in the direction of the stroke. It will move away from the stroke. So that's exactly what you see here. So if patient has a stroke on the left side, so the left frontal eye field is affected, so he cannot move his eyes to the right side, then he will have an eye deviations away from the hemiplegia towards the stroke. So this, for example, this I will give him an eye stroke scale of like a score of 1 on gaze preference. Whereas if his eye forcefully deviated to the left and head tilted to the left like that, then I will give gaze deviations. I will give him a score of 2. Whereas if he can move his eye right and left, then it is 0. So what you see in A there, it's a typical left gaze preference due to left hemispheric stroke. Here, patients has a hemiplegia on the right side and gazing towards the hemiplegia, he cannot gaze to the left. It means away from if this is the lesion here, it means it's away from the lesions. So the possibility here that he has either has a left brainstem stroke. For that reason, he cannot gaze towards the lesion, gaze away, or it has been reported that these patients can have thalamic hemorrhage or basal ganglia hemorrhage. That's what we call the wrong eyesight. Wrong eyesight. So in general, cortical stroke patients gaze towards the stroke. Brainstem stroke patient gaze away from the stroke. Both these, let's say that both these patients has a left cortical stroke, left brainstem stroke. Left cortical stroke gazing towards the stroke. Left brainstem stroke gazing away from the stroke. So we finished the level of consciousness. We finished the gaze deviations. The item 3 is vision, visual testing. And the way, مثل ما Dr. Ziad, how did he explain it like 2 weeks ago? You have the visions in confrontations. Close one of your eyes. Tell me how many fingers do you see? 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 So I will divide the image, the visions in monocular eye to 4 quadrants. 1, 2, 3, 4. And in the right eye to 4 quadrants. 1, 2, 3, 4. So I will cover this, then cover this, then 1, 2, 3, 4. So I will confrontations 30 centimeters and cover uncover test. So, and if there is visual intact, I'll give them 0. If there is a quadranopsia, if there is difficulty seeing in quadrant of the visions in both eyes, then it's called partial heminopsia. It means quadranopsia or visual extensions. If they have a visual extension, I'll give them 1. If it is upper and lower quadrant homonymous heminopsia, right or left, then I will give them 2. Cannot see anything, then I will give them a 3. So 0 normal, 1 quadranopsic, and 2 homonymous heminopsic, and 3 bilateral cortical blindness that can be seen with the tip of the basal artery clot that causing a bioccipital stroke. And here's an example. Like which patients you think out of all this has a stroke? And which one is not consistent with the stroke? So this patient has a right inferior homonymous quadranopsia. This patient has a right homonymous heminopsia. This patient has a bitemporal heminopsia. And this patient has a left upper homonymous quadranopsia. Which one is not consistent with the stroke? This one is not, this is more of chiasmal lesions, like chiasmal lesions, because it's a bitemporal homonymous heminopsia. Bitemporal, not homonymous, bitemporal heminopsia, not homonymous. Homonymous is in the same side. Bitemporal heminopsia. This is consistent with chiasmal, not brain. Whereas this, the A, B, and C consistent with contralateral hemisphere. B likely occipital, A likely parietal, and D likely temporal. So number 4 items, we will move to the facial muscles. Facial muscles. And it's simple. You ask the patients, could you please smile? So if their smile is symmetric normal, then this is he will score 0 on facial muscles. If there is a flatness of the nasal labial fissure, it's called nasal labial fissures. If there is a flatness here, flatness of the nasal labial fissure, then you will score 1. If there is total, like lower motor, total or near total paralysis of the lower part of the face is more obvious, I give them 2. Now, if there is a complete paralysis, like what you call lower motor neuron of one side or both sides, then I will give them 3. So 0 normal, 1 slight facial weakness with a flatness of this nasal labial fissure, 2 obvious central facial weakness, 3 lower motor neuron facial weakness on one side or both sides. Now, lower motor neuron, you can see it with a brainstem stroke. And mainly when you have a bilateral lower motor neuron, if it's not peripheral, this could be central from brainstem. So the facial muscles, as you remember, and this is the anatomy, the upper part, the lower part. The lower part of the face is the other way. The upper part of the face is bilaterally innervated, whereas the lower part of the face, the orbicularis ocular muscles, is this part, and the frontal part is bilaterally innervated. For that reason, if patient has a stroke, quite often the upper part gets spared, whereas the lower part of the face, the cheek and the mouth angles, orbicularis oralis muscles, this is contralaterally dominant, mainly contralaterally innervated, as you see there. So patients with a stroke will have a lower facial weakness, and that's what we call a central facial weakness. So if the lower face is affected, that's what we call central facial weakness. If all faces will be affected, that will be consistent with the lower motor neuron facial weakness, either Bell's palsy or brainstem stroke, as you see in this the demonstrations. بعد الfacial weakness, and we'll move to the motor exam. And the motor exam, you want to assess the strength in 4 limbs: in the right arm, left arm, right leg, left leg, and each limb you give a score out of 4. So the way I do it, I ask the patients, could you please stretch your arm like this? Okay, they stretch it there like this, their arm, straightening their fingers for 10 seconds. 1, 2, 3, 4, 5. No drift, I give them 0. If there is a slight drift within 10 seconds, I give them 1. If there is, I give them 1. If patients can hold their arm against gravity, but within 10 seconds drop, I give them 2. If patient has no effort against gravity and the limbs fall immediately and they have some movement, I give them 3. If there is no movement, I give them 4. So straight your arm 10 seconds. 1, 2, 3, 4, 5. Normal, 0. Drift, 1. Straighten your arm like this for 10 seconds. 1, 2, 3, 4, 5, 6. Then 2. So some effort against gravity, I give them 2. And 3, there is no effort against gravity. There is no effort whatsoever against it, but there is a movement in the arm. And 4, when there is no movement. I will do it on right arm, then left arm, then right leg and left leg. However, the leg, ask them to straighten their leg, one of their leg up, but not for 10 seconds, for 5 seconds only. If the legs stay for 5 seconds without drift, then you give them 0. If there is a drift of the leg but do not hit the bed, I give them 1. If there is some effort against gravity, but the legs fall to the bed by 5 seconds, then I give them 2. If patients cannot lift their leg above the bed, there is no anti-gravity effort. There is no against gravity efforts, but there is movement in the leg, I give them 3. If there is paralyzed, no movement whatsoever, I give them 4. So very much 0, 1, 2, 3, 4 scale in the leg, like the arm. However, the arm, straighten your arm for 10 seconds, whereas the leg, straighten your leg for 5 seconds. You do it for both legs, you do it for both arms. Then, after that, number 7 item, limb ataxia. So while there are eyes open, touch my finger, then take it to your nose. Finger, nose, one side, then the other side. Then heel to shin, take your right heel on the left shin, bring it down, up, up. Then the right heel on the left shin, bring it down, up. So if it's normal, you give them 0. If there is ataxia on finger to nose or heel to shin, one of them, then you give them 1. If there's ataxia in two limbs, arm and leg, bilateral arm or bilateral leg, or one arm and leg, then you give them 2. So it will be 0, 1, or 2. Then after that, item 8 is the sensory exam. Sensory exam, you test the tactile sensations only in the bilateral face, bilateral arm, and bilateral feet. So touch it, both feeling the same, normal, 0. If there is a slight decrease sensation in one side, comparing with the contralateral side, either bilateral face or arm or leg, then I give them 1. If there is a total loss of sensation, severe to total loss of sensations in one side, in the face, arm, and leg, in comparing with the contralateral side, then I will give them 2. So it'll be 0, 1, or 2. We finished the sensations. Number 9 is language. And the language component has several components. One is a fluency, one is naming, and the third part is slurring speech. This are 3, or articulations. Let me just see, hopefully I'm going to finish this one. So the best language, number 1, testing aphasia, fluency. You show them this card called Boston card. Could you please explain what's going on in this card? Okay, there is a mother washing this, the dishes, this, the boy is trying to get the cookies, this gonna fall, this. Okay, great, they're fluent. If they have a difficulty explaining it, not explaining it fluent, then I give them 1. If they're severely limited, I give them 2. If it's globally, if they cannot say any words or cannot follow any commands, then I give them a 3. So 0, 1, 2, or 3 based on the severity of speech. But to assess fluency, you show them that what we call the Boston card. And all these applications can be on your iPhone or on your smartphone or Android phone. So first thing, what happened in these pictures? You ask them to explain what's going on in these pictures. Then could you please name these objects for me? What is this? 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 And by the way, there is, I think, in Al-Khalij, I think they come with Arabic versions for the inner stroke skill. So all what I'm saying is available in Arabic versions. So fluency, naming, and the third thing's reading. Could you please read these sentences for me? What I do sometimes in patients who doesn't have aphasia, I ask them to read the last sentences. If they read it, it means they can read everything. So best language when they can fluent, name, and read. So 0. If they have a mild fluency difficulty or naming difficulty or comprehension difficulty, mild to moderate, I give them 1. Whereas a severe one, they have a difficulty explaining and being fluent, but they can follow commands, for example, or they cannot follow commands, but they are coming with a lot of errors in speech, I give them 2. If they are globally aphasic, they cannot understand and they cannot speak, totally mute, globally aphasic, then I will give them 3. So it will be 0, 1, 2, or 3. Then after that, item 10, slurred speech. I'm going to try to wrap this. The slurred speech, ask patients, you show them this card. Could you please say these words after me? Mama, tip top, 50-50, thanks, huckleberry, baseball players. So they say these words. If they say it normally, it's normal. If there is an articulation difficulties, then you give them 1, mild. If it is severe, their speech is so slurred, you cannot understand them. Mama, tip top, 50. Then I'll give them 1. Or as they say, then I will give them 2. So 0, 1, or 2. The item, I think this is the last item. Yeah, the last item is extinction and inattention, which is neglect. And quite often see to the right hemisphere, hemi neglect on the left side. You do double stimulants. I'm touching you on the right side. Okay, I'm touching you on the left side. Then close your eyes. Which side I'm touching you? Right, left, or both? Then if they neglect one side in the presence of double stimulants, that's what we called sensory neglect. Visual neglect, which hand is moving? Right hand. Which hand is moving? Left hand, with eyes opening. Which hand is moving? Right hand. So they neglect vision in the presence of double stimulants that we call visual neglect. So sensory neglect, visual neglect, then no neglect, you give them 0. Presence of visual, tactile, auditory, rarely I do it, or in attentions, I give them 1, where they have a profound neglect, like for example, visions severely, like looking to the right side, they are not aware of anything on the left side of their bodies and all these things, then I will give them 2. So it will be 0, 1, or 2 by doing double stimulants, sensory stimulants, or visual. I do usually visual and sensory. Now, and these are the YouTube videos about the NI stroke scale, about the pitfalls of NI stroke scale, and etc. More to discuss with this, and this about pre-identifications and all this. We can discuss that in another lectures. I'm running into 1 o'clock now. I have to stop. So any questions? I know we don't have a lot of attendance today. Sounds like it's very simple.
No question, inshallah.
Inshallah. So Dr. Ahmed, so inshallah, I'm gonna just see if I can share this. Oh, not this one. This one.